Hello, today we're going to talk about dietary changes for lowering the cholesterol. The central thesis of this is that dietary patterns and not nutrients dictate cardiovascular outcomes. The old dogma was we should eat less eggs and this will affect your serum lipids and cardiovascular events. However, this did not turn out to be true. Dietary patterns are more important. Large scale trials demonstrate that whole food, plant predominant dietary patterns, such as Mediterranean diet, are superior for secondary prevention and can even reverse atherosclerosis. The mechanisms are synergistic. The benefits are driven by the combined effects of high soluble fiber, unsaturated fats, antioxidants, phytochemicals, alongside lower saturated fat and cholesterol. The clinical goal in the modern therapeutic objective is to use evidence based dietary patterns with or without pharmacotherapy to achieve risk reduction and reverse disease potentially. Now, the old dogma was, for example, no eggs or no more than one egg, things along those lines. Um, they recommended less than 300 milligram per day dietary cholesterol restriction. The evolving evidence, such as the 2015 and 2020 American Dietary Guidelines, removed the upper limit for dietary cholesterol. So, they found that 1 to 3% of the cholesterol was dietary in origin. So, there's a metabolic feedback loop that regulates cholesterol homeostasis. An addition of 100 milligram per day of dietary cholesterol increased serum cholesterol by only 1 to 3%. So then subgroups matter. There are some people who are hyper responders where there is an increase in circulating LDL and HDL due to differing absorption synthesis rates. So these recommendations could not be generalized. Dose response was found for consuming up to 7 eggs per week did not increase cardiovascular risk in the general population. In the patients with type 2 diabetes, there was evidence suggesting that there is higher cardiovascular disease risk with increased egg consumption. Meta-analysis showed 69% greater possibility of experiencing CVD. So the clinical takeaway from reviewing all this information shows that a blanket restriction on dietary cholesterol is outdated. Now, not all saturated fat is created equal. In the older studies, they linked higher saturated fat to higher serum cholesterol level. However, replacing saturated fat with carbohydrates, especially refined, did not change cardiovascular disease risk. While LDL-C decreased, HDL also fell. Replacing saturated fat with polyunsaturated fats, PUFAs, showed a significant reduction in cardiovascular risk. And also the food source of saturated fats mattered. Meat-derived saturated fat were directly associated with higher cardiovascular risk. This was compounded by other components like sodium in processed meats. Dairy-derived saturated fat was associated with lower cardiovascular risks, potentially due to minerals in the dairies. Plant-derived saturated fat, for example, coconut or palm oil, had a neutral effect. Lauric acid raised LDL but also HDL. Thus, the clinical takeaway from this is a nutrient-rich, nutrient-centric limit on total saturated fat is less effective than a food-based recommendation. The new paradigm, clinical evidence points to overall dietary patterns rather than focusing on single nutrients. In the EPIC study, which had almost 25,000 patients, there was a lower risk of chronic disease associated with higher intakes of whole grain bread and raw vegetables. There is a higher risk of chronic disease associated with higher intakes of red meat and butter. In the ERIC study, greater adherence to plant-based dietary indices associated with 16% lower risk of cardiovascular death and 31% mortality. Healthful versus unhealthful plant-based diet indices. This is a critical distinction that clarifies diets rich in whole grains, fruits, vegetables, nuts, and legumes are protective. Diets high in refined grains, sugary drinks, processed plant foods are null or associated with adverse outcomes. Therefore, consumption of a plant-based diet versus a non-vegetarian diet decrease total cholesterol, LDL, apolipoprotein B, C-reactive proteins, and decrease the risk of atherosclerosis. Now, the landmark interventional evidence comes from Ornish trial. In this study, it was a lifestyle adjustment trial. It was published in 98, quite a while back. The experimental group had 10% fat, whole foods, vegetarian diet, aerobic exercise, stress management, smoking cessation, and group support. No lipid lowering drugs were used. Control group underwent usual care. In 5 years, when they studied atherosclerosis regression versus progression, the experimental group had average percent diameter stenosis decreased by 3.1 percentage points, almost an 8% relative improvement. The control group, average percent diameter stenosis increased by 11.8 absolute percentage point, 30% relative worsening. Looking at cardiac events, the experimental group had 25 cardiac events, the control group 45 cardiac events. This is the change in coronary artery stenosis. Comprehensive lifestyle changes with a very low fat, whole food vegetarian diet at its core can cause regression of atherosclerosis. Now, Mediterranean diet was studied in this trial called the CORDI-PREV trial, published in 2021, randomized trial controlling 1,002 coronary heart disease patients, comparing two healthy dietary patterns, Mediterranean diet versus low-fat diet. In the Mediterranean diet, there was 35% fat, 22% of it from unsaturated fat sources, less than 50% carbohydrates, and rich in extra virgin olive oil. Low-fat diet had 28% fat, 12% from unsaturated, more than 55% carbohydrates, and this was a recommendation of the NCEP program. The primary finding was change in carotid media thickness. In the Mediterranean group, statistically significant decrease in intimal media thickness at 5 years was noted that continued to 7 years. In the low-fat group, there was no significant modification of intimal media thickening. Mediterranean diet group also produced a greater decrease in maximum carotid plaque height. So here's the graphic representation of that trial. Secondary prevention, a Mediterranean-rich diet in extra virgin olive oil was superior to guideline-recommended low-fat diet in halting and reversing progression of atherosclerosis. The key mechanistic component could be the potent LDL lowering effect of soluble fiber. One of the primary drivers of lipid lowering effects of plant-based diets is their high concentration of soluble fiber. Soluble fiber supplementation significantly reduced LDL cholesterol and total cholesterol and triglycerides and apolipoprotein B. There was a dose-response relationship. A linear dose-response analysis showed that a 5 gram per day increase in soluble fiber supplementation was associated with a 5.6 milligram per deciliter reduction in LDL cholesterol. There was also a nonlinear effect. The greatest decrease in LDL cholesterol was observed at a dose of 10 gram per day of soluble fat. Thus, the potential mechanisms proposed include that there's a viscous solution that delays gastric emptying, it binds bile acids, increasing excretion of cholesterol in the feces, modulates the gut microbiome, and produces short-chain fatty acids that influence lipid metabolism. Clinical takeaway, tangible target of increasing soluble fiber intake to 10 to 25 gram per day as recommended by NCEP TLC guidelines is a potent non-pharmacological strategy to lower atherogenic lipids. Another mechanism to consider is the quality and source of unsaturated fats. Monounsaturated fats benefit when they replace saturated fats. The source matters. Plant-based are superior to animal-based. When you consider polyunsaturated fats, marine-derived EPA and DHA show consistent, strong evidence to lower mortality. Plant-based also show benefits. Now, the modern recommendations to enhance the conversion of ALA to long chain 3 PUFAs, and this is done by replacing animal fats with plant derived monounsaturated fatty acids such as olive oil, and increase intake of marine or plant-based polyunsaturated fatty acid. So, moving on to therapeutic lifestyle changes. Reduce the saturated fat to less than 7% of total calories. Decrease the dietary cholesterol to less than 200 milligram per day. Total fat 25 to 35% of total daily calories. Reduce sodium for optimal blood pressure control. Increase plant sterols and stanols intake to 2 grams per day. Increase soluble viscous fiber to 10 to 25 grams per day. This should be designed to be implemented in stages. After initial 6 weeks focus on reducing saturated fat and cholesterol, the LDL response is checked. If the goal is not met, then plant sterols and soluble fibers are added to intensify the regimen. Then this includes weight control and at least 30 minutes of intense physical activity a day. So it's a total package. You have to not just consider saturated fat, but also the polyunsaturated, the monounsaturated, the total fat, the carbohydrate, the dietary fiber, protein, and total cholesterol. So the frontier prevention for aggressive LDL lowering for atherosclerosis prevention is there's a lot of rationale now for ultra-low LDL-C. Numerous studies have shown that lower is better. There is no J-shaped curve anymore. Now, there's a synergy between plant-based diet and intensive pharmacotherapy. So, lower the better. The guideline target keeps on getting lower and lower, and the lower LDL seems to stabilize the plaque. So, the modern approach to cardiovascular nutrition would be to focus on food patterns, not nutrients. Prioritize diets with high vegetables, fruit, whole grain, legume, nuts. Rethink fats. The goal is not low fat, but replacing saturated fats with monounsaturated fats from vegetables, especially olive oil, and polyunsaturated fats from marine components. Leverage key components. Actively increase intake of soluble fiber, 10 to 25 grams per day, plant sterols, 2 grams per day, and embrace a lifestyle synergy with increased exercise. Now, aim for aggressive targets in high-risk patients. The old strategy was single nutrient focus. The new strategy is dietary pattern focus. Here is an example plate of what the modern strategy should look like. Now, the foundation LDL cholesterol remains the primary therapeutic target. ATP classification of LDL cholesterol, optimal was less than 100, near optimal was 100 to 129, etc. These have all changed with evolving evidence. Another thing to consider is the consensus of trans fats and cardioprotective role of unsaturated fats. Trans fats are industrial fats from partially hydrogenated oils consistently and strongly associated with increased cardiovascular risk via higher LDL-C and lower HDL-C and inflammatory pathways. Ruminant trans fat is naturally occurring in beef, lamb, and there is no convincing association between this and cardiovascular risks. Whereas monounsaturated and polyunsaturated fats come from plants and fish, there is strong evidence of cardioprotective effects. Therefore, we should emphasize that trans fat-free labels can be misleading, and the clinical recommended dose of EPA and DHA intake for primary prevention is 300 to 600 milligrams a day, secondary 9 to 1200 milligrams a day from natural sources. Going back to the egg story, a meta-analysis showed that white egg consumption has no effect on cardiovascular disease risk in healthy people, whereas in diabetics, there's a 69% greater possibility of experiencing cardiovascular disease when consuming more than one egg a day. Revisiting the soluble fiber supplementation, there was a dose-response meta-analysis of 181 randomized controlled trials, and in their analysis, they found that each 5 gram per day increase in soluble fiber supplementation leads to a significant reduction in total cholesterol by 6 milligram per deciliter and LDL by 5.6. The greatest reduction in LDL-C is at 10 gram per day, and the greatest reduction in triglycerides is 15 gram per day. The TLC diet, the macronutrient profile, saturated fat less than 7% total calories, total fat 25 to 35% total calories, dietary cholesterol less than 200 milligram per day, dietary fiber 20 to 30 grams per day, plant stanols and sterols 2 grams per day, viscous soluble fiber 10 to 25 grams per day, protein 15% of total calories, carbohydrate 50 to 60% total calories. A healthful plant-based diet has low energy density, low saturated fat, high fiber content, high levels of antioxidant nutrients, and low levels of certain dietary factors. It improves the lipid profile, it enhances endothelial function, it decreases inflammation and oxidative stress, and it improves the gut microbiome, reducing cardiovascular. Going back to a classic pyramid idea, the overarching principle is that the quality of diet is paramount. The foundational thing for everybody to do is fat quality. Replace saturated fats from red meat with PUFAs. Eliminate industrial trans fats. De-emphasize dietary cholesterol. Targeted intervention, add soluble fiber, 10 to 25 grams a day. And follow a TLC diet, as we just discussed earlier. A healthful plant-based diet should be strongly considered. It should be noted that decades of research have led to widespread confusion in the past. We've heard eggs are bad, saturated fat is not the enemy, high-fat diets are back, etc. Again, re-emphasizing that not all fats are bad, as is illustrated in this figure. Meat increases cardiovascular risk, dairy reduces, plant sources have a mixed effect. Plant-based monounsaturated fatty acids have a lower coronary disease risk. Animal-based are not associated with lower risk. In conclusion, the solution isn't a single nutrient, it's the entire dietary pattern. Foods associated with lower risk are whole grain bread, raw vegetables, and coffee. Associated with higher risk are red meat, butter, and low-fat dairy. And finally, a heart-healthy plate looks like this. Half your plate should have vegetables and fruits, 1/4 whole grain foods, and the 1/4 protein foods. Thank you for watching. More to follow.